chickenpox, for example. Chickenpox also appears as blisters on the skin. Then it progresses to pustules, so these little blisters can be to fill with a whitish fluid that looks like pus, and so they begin to dry and scab, and after that the scab falls off. That is the classic progression of the rash. In terms of the body itself, the classic progression is face and then palms of the hands, soles of the feet, and then to the body itself. That also is a classically described progression. Another classic picture from monkeypox from past years is the swollen lymph nodes. Recall that the World Health Organization and all countries of the world eradicated smallpox, and the eradication of smallpox was declared in 1980. And so that disease is noble, even when they've been around for a very long time. The reason I raise this now is that at the time of eradication of smallpox, monkeypox had already been identified in people in 1970, a period of about 10 years when we had a little bit of both. And the distinction between smallpox and monkeypox was the swollen lymph nodes. If a child had swollen lymph nodes, it was more likely to be. We know already because countries that are familiar with this infection, this infection that comes from the animals in the forest actually, they survived for a long time. What we are seeing today, still we have that picture, but we also have a higher proportion of cases where the rash may begin, possibly because of the nature of the contact. Again, we don't know, but we're seeing more cases where the rash begins in the genital area, which is not in there, but it's more frequent now, and sometimes it tends to stay there. So it's also possible that the rash may not be visible because it may be covered. If it doesn't reach your hands or your face, then it may not be seen. However, it's important to consult your healthcare provider because that rash can even contaminate your bed sheets, your clothes, and so on. And so you don't want to expose people in your family, for example, or your other social related materials, which is also one way in which monkeypox can spread.
Brings us on to another question. I think it fits in well again. So we've been saying, right, not everybody's at equal risk, and in communities where there are people, in social networks where there are people with monkeypox, those who are most at risk are their close friends, their close contacts, their family members as well. Historically, monkeypox would spread between family members and also sometimes health workers who are helping those people. So here's a question from Vasiliki Angoridi, and this will be for you, Andy. Elaborate more on the MSM comment, because many officials have considered that a rushed, superficial approach that only fuels discrimination. So just talk a little bit again, maybe even just again, why we're having, for now, an inclusive approach, focusing in part on men who have sex with men, but as Dr. Van Kerkhove explained earlier as well, we're also asking pathology clinics, primary health care, and elsewhere to see if they can find further cases of monkeypox. So that was a very big preamble, but just wanted to pass back to you, Andy. Can you explain, especially with communities of MSM?
Of course. So yesterday we issued some interim public health guidance for gay, bisexual and other MSM. And it really answered the question you just posed to me, essentially. And really one of the things that we've, again, it's early days and we don't have all of the information yet, but this demographic is that really does take care of health screening when it comes to potential STIs. So, for example, we know that MSM, if they do spot an, they're likely to want to get it sorted out quite quickly. So they'll want to go and seek health advice. They'll want to access an STI clinic if they have services about responding to unusual symptoms might be part of the story. And again, more of this will come. So I do think that could definitely, similarly, I think the classic thing here is that, we have this atypical outbreak. It has been widely reported in a number of countries. Sometimes the reporting is very good. Sometimes it does come, sadly, with some misinformation, stigma and discrimination community, but perhaps also unintentionally suggesting that this is an African disease, only using images of black skin, for example. And so there are ways that we can work with community on really decades of experience around tackling stigma and discrimination with HIV. We want to apply those lessons learned to this experience. And again, we colleagues on COVID as well around the same issues. How can we make sure that communities are helping inform messaging, helping us with the surveillance around, myths and misinformation, collectively directing people to trusted sources of information, and really encouraging people to act appropriately, responsibly, and really, do their very sources of information and advice.
Can I come in on that one? So in addition to what you've described here, I think we need to, when we respond to something that looks for whatever reason, as public health professionals doing an outbreak investigation, we need to describe what we see, right? We describe what we're learning. It's not to say that we know everything, what's going to happen tomorrow, but today we need to describe what we're seeing, and where we saw the first cases are one of the indications as to why this perhaps is a difference. It's about discrimination, it's not about stigma, it's about saying, where are you seeing the first cases? How can that help you do contact tracing? How can that help you with the investigation to go and find out the type of source to begin with? But where is it spreading now, and how is it spreading now? These are questions we ask ourselves in the middle of an outbreak investigation.
I know colleagues have said that describing what we know now, and we share more information as we get it. So a couple of administrative things. I said this in the first intro and didn't say it in our second intro. Why are we not where we've been used to seeing, for example, Dr. Van Kerkhove and Dr. Mike Ryan in their Facebook lives? We're in an open space. We always say try to be in open spaces as much as you can. There's more air circulation here, so masks, we're just not wearing them now. We would wear them if we were in closer proximity. We've all been vaccinated, and as part of this health assembly, everybody is meant to do a COVID test if their tests are negative. So we've all done that as well. Another administrative thing, I know a lot of our journalist colleagues are watching us here, but these Ask WHO Lives are for the general public. Please write to our address, as it always is, and we'll get back to you that way. And we've seen this is really for the public. And Dr. Van Kerkhove, I want to go to you next. What is WHO doing about this? We've touched on a few things, but can you give us the overview of what WHO does, but in this situation?
I can, and then I'm going to ask Rosamond to supplement because there's quite a lot of activities that are ongoing. I mean, one of the things we really need to do right now, we're working with partners. We'll always work with partners in science, but we have some major areas of focus that we are working on right now, and we are working with member states to achieve things. One is we have to raise awareness about what monkeypox is, and we have to expand surveillance. So particularly in countries that aren't used to seeing monkeypox, we need to equip ministries and governments and countries sure that people who may be suspected as having monkeypox get the appropriate clinical care. We want to stop human-to-human transmission. We can do this in the non-endemic countries, and this is really, we're in a situation where we can use public health tools of early identification, isolation of cases, supported isolation of cases, talking with communities, listening to communities to be part of the solution. This is not about WHO telling the world what to do. It's about working with communities to say, how do we come up with solutions that fit in this. But I do want to reiterate that this is a situation and we can stop human-to-human transmission. We also want to protect frontline workers and protective equipment, and we want to utilize all of the countermeasures that are in place. There are some antivirals, there are vaccines, but we have to utilize these most appropriately for those who are most at risk in infection. And again, lastly, overarching is to advance our understanding about what monkeypox is. So we're going to be having a big global meeting around R&D, from everything from the epidemiology all the way through diagnostics, therapeutics, and vaccines, and that'll be happening next week. But Rosamond can supplement that because there's so much other activity happening there.
Well, I think you've covered a lot of it, Maria. One addition that we could offer is that, as you say, we work with experts around the world on a regular basis. You've mentioned it as well, Andy. And what they help us do is draft the guidance. So we have materials online. Some of you may have already looked at the training materials that are already on the Open WHO platform. There is an introductory course there, that really takes you through quite an extended course of 2.5 to 3 hours. And if you set aside a little time and you want to do that, you can learn a lot about monkeypox. Anybody can do it. It's free WHO platform, but it's free and anybody can do it. I would like to mention that course was draft was prepared over the last couple of years, and it was released in January, has now become apparent in May of 2022. So you'll see that the information was really targeted towards health workers in the Democratic Republic of Cameroon. This was our target audience for that training. So don't be surprised if you see that the voices, the sounds, the images, the pictures are designed for our target audience. We're going to be looking at these, but don't think that we just made up this course yesterday, because it really has taken some effort, and we're going to continue to make that effort to provide information. In order to do that, we will also, for health authorities around the world, for the ministries of health of our member states, and so it will go at a different level. They will also be available online, and you will also be able to look at them. But for every product that the WHO produces, the NICA. And so this is what we try to do. We try to tailor the messages and the audiences, the products and the materials for you. And it's a tremendous privilege to be here today with you, the public. And we do the same for different audiences, including our member states' ministries of health.
I think that's another example of the ongoing work WHO has already. But I've heard you say this already, Dr. Van, in previous settings. There hasn't been enough work on monkeypox. There aren't widely available vaccines, there aren't widely available therapeutics, and yet there are people who experience this unpleasant and in some cases deadly disease, and more needs to be done. And perhaps this is an opportunity, now that the world's eyes are focused on this, that some of those things can happen. I have a question, 3113, asking, is it true that the smallpox vaccination can protect against monkeypox as well? And some information related to that, I'm not 100% sure, but I think that's back to you, Dr. Lewis.
Right. So, of course, there was smallpox vaccines available, and those contributed tremendously to the eradication of smallpox. Learned that it was observed, and studies were done, that the smallpox vaccines used at that time were protective against monkeypox about 85% of the time. If you've been following, of course you have been following information around COVID and other diseases, you'll know that 85% is not perfect, but it's also not terrible vaccines, because although smallpox was eradicated, research has continued for the last 40 years, and people were wondering why? Well, this might be a good example of why. That these viruses are other. All those years of research in diagnostics, in treatments, and in vaccines that will be brought. And now we have the benefit of all those years of research in diagnostics, in treatments, and in vaccines that will be brought to bear upon the situation now. However, because these are relatively new, they are not yet widely available. They are available to some ministries of health in national stockpiles, but they're not yet widely available commercially. So another area of work that we'll be engaging in will be to work with the and sector and industry to see what we can do now to enhance availability of these products.
Because I think we have a real opportunity here. You know, as Rosamond has described, products that are available, but they're not widely available yet. And we have an opportunity here to use these appropriately and to use these for those who are at risk. So we will be making recommendations on who, should be prioritized for this, something that everybody needs. It is a virus that is spreading between people who are coming in close contact with those who are cases. And we really need to discuss, evidence-based measures, access, and equity. We really, as a global community, have another opportunity to do that, whether it's from manufacturing or whether it's from our ministries of health and whether it's the general public, to make sure you understand what the risk is. And we will be doing these regularly, and inform you about what the risk is. And of course, we'll issue information through all of our channels to member states and to the public. But we have a real opportunity here. And there are some parallels in terms of access, and this is really important.
Communities are already saying to us, if we get this right, if we contain this, if we get the access right, we have to do this for the endemic countries as well. And I think this is where the opportunity is coming in, and the communities have already spotted this, they're already talking about it, and it's something that I think is a good approach.
Thank you. And with that, we're going to wrap up. We haven't answered all your questions, but we do see and hear your questions, and we fold the answers into our Q&A, into the products we put out on social media platforms. So continue to ask those questions. That helps us know what you need to know. If we're not communicating, we help by seeing if your questions show that confusion as well. So do keep giving us your questions through #AskWHO. I want to thank our experts for being with us today. We had Andy Seal, who's with the WHO program on hepatitis, HIV, and STIs, that's sexually transmitted infections. Thank you very much. Comment from somebody saying that you were totally right, it's because MSM are extremely good. And somebody saying that you were totally right, it's because MSM are extremely good at checking themselves, that we have part of this signal. So thank you for being with Smallpox Secretariat in WHO's Emergencies Program, and I think maybe you understand a little bit more about how smallpox and monkeypox, maybe you understand a little bit more about how smallpox and monkeypox are related now. And lastly, we have the most familiar face of all, emerging diseases and zoonoses.